Okay, welcome to SLP 215. Okay, module 2. All right, so last week, just a couple, um, there were, I did go back and grade the quiz. There was one that was auto graded, but some people had it right and it was marked wrong. So I'll double check, but I'm pretty sure everybody, I, I fixed it. So it should be accurate. If you think it's not accurate, send me a message. So there's one or two questions that was fill in the blank that I think you got it right, but they scored it wrong. So I did fix those. So last week we talked about executive function. This week we're talking about dysphagia. So, and I don't say it like the West Coast because I went to grad school in the Midwest. So I say dysphagia. Other people say dysphagia. And other people say dysphagia, like with the ja in there. I don't know. So I do say it funny. Some of the other people make fun of me. But I haven't worked really. I haven't done a lot of feeding therapy here in the West Coast. I've mostly done schools, clinic, and home health. Last time I worked in a rehab hospital where I did swallow studies and things like that was in the Midwest. So I think it's more dysphagia. I'll have to read on the ASHA website how they decided to. I guess there was a discussion on one of the ASHA conventions on how to pronounce this word. Okay, so a couple different things. Feeding. Now, number one thing to know at this time, you guys as SLPAs are not licensed to do feeding. Now, I say that at the moment, I say that at the moment because I do feel some of that might change, where you're not necessarily doing swallow studies, but you might do feeding therapy. I don't know. I think with the new things for ASHA, I think some things will change here in the near future. But since you aren't licensed at this point in time to treat feeding, you need to know what's feeding therapy and what isn't. And also, a lot of times these things don't happen in isolation. So somebody might need feeding therapy, but they might also need other therapy that you are licensed to provide. So just some things to be aware of. And I think that's what gets hard if the client you're working with does need feeding support, but you're not licensed to do that. And being aware of what's feeding, what's not feeding, what's safe and within your licensure and what's not. So you kind of need to know what it is so you know what it's not. So chapter 15 has great information about feeding and swallowing disorders. So there's some PDFs on dysphagia, and food sensitivities is another one. So in these videos, we have some just what does a simple swallow study look like? So there's some videos. This might be something that somebody does in the hospital. But considering, one second. Okay, can you guys see that? Hopefully.
Yes.
Yes.
Okay, good. Okay. So dysphagia is typically used to describe a disorder of swallowing. The main consequence is choking and aspiration. And when we say aspiration, so aspiration in itself is the inhalation of a foreign object that goes into your lungs. So that could be food or liquid, or Lord help you if you actually have kind of a foreign object in your lung. Now, what happens is then the next thing, not just choking, but aspiration can then cause a lot of other components like aspiration pneumonia. So just because somebody aspirates doesn't mean they have a dysphagia. So somebody might on occasion choke on something or aspirate, but the dysphagia is really this disorder where they're constantly aspirating food or liquid in their lungs. So it's more of a chronic thing, a once in a while thing. I don't know if anybody's been eating and started laughing and choked, or gosh, I aspirated on some coffee the other day because I was going to try to yell at the dog at the same time I was drinking, which is not a good idea. So just some things to think of. Dysphagia is a chronic aspiration where you're chronic, it's chronic in that you're aspirating food or liquid into the lungs. So some causes. Here are, and these are just the tip of the iceberg. There can be so many reasons for it. So a lot of times we're looking at acquired or traumatic brain injury, other neurological deficits, and this is the gamut from a syndrome to a progressive neurological disorder like ALS, Parkinson's, MS. So looking at that, cancer, you've had treatment, you've had radiation, it's making things, weak, and any other muscle issue. And then kind of that secondary complication could be anoxia, so lack of oxygen to the brain, pneumonia, other intracranial pressures, seizures, lesions. All of these things might contribute to dysphagia. So somebody's been intubated for a long time, been in a coma, those kinds of things. Their whole body atrophied for whatever reason, and now they're weak. So definitely some components on why swallowing can be a challenge for a huge variety of reasons. And then kind of look at kind of the 4 stages of swallowing. So the oral prep, and then oral, and when we say the bolus, that's whatever you're chewing food. And then pharyngeal, so that when we say pharyngeal, we're kind of referring to the throat. And then esophageal is where it enters the pipe, so to speak. Your esophagus is what kind of connects your throat to your stomach. Now, a couple of different things too we also need to remember. So the esophagus and the trachea, 2 very important structures, and they're right next to each other. So looking at the trachea and the esophagus, they are like next to each other. They are what we call neck and neck. They are butted up against each other. So you've got a hole in your trachea. Could you have damage to the esophagus? Yes. Could they puncture? They're trying to intubate you. And could they do some damage to the esophagus? Absolutely. So some of those things too, if you've been in a trauma, meaning like an accident of some kind and they need to do some emergency things, these things can happen. So symptoms of dysphagia: coughing, choking, coughing after swallowing, uncoordinated chewing or swallowing, leakage of food from the mouth, leakage of food from the nose. Now, and when you think of little babies, you look for those signs. Are they choking? Because a lot of times it's quiet. It's not always they're choking. They don't have any air. So pocketing of food definitely can show some signs. So if they constantly have food kind of stuck in the side. The other thing too is gurgling or wet vocal quality. So somebody eats and you hear that wet vocal quality, that should be an alert. So again, you'll see some of these things where you're working with a client, especially if you work in like a rehab setting, short-term rehab, long-term rehab, you'll see a lot of these things, especially as they're kind of gaining strength. So some things might be difficult. A lot of times they have to use a modified diet. So kind of look at what we do for an assessment. So kind of that formal assessment is the modified barium swallow study. So that's where you swallow this food, which is horrendous, that's got barium in it so they can see it. It's usually food or a liquid. And then you're usually in the radiology suite with the radiologist, and that's kind of the radiology technician. So it's usually you and the radiologist look at that. You try different textures, what's safe, what are they, how do they swallow? You can usually see right away if it goes down into their lungs. So those are some things we do. Obviously, there's also what we call a bedside swallow study. And a lot of times we see some concerning signs and then we send them to do this, because this isn't just your average test you want to do. And not to mention, it does subject people to some radiation. So we don't just, throw these out all the time. But anybody that we're really concerned about, and it's critical that we have a good idea of their capacity to swallow and eat, or what level of diet they should be on. So I don't know if any of you have been in the hospital recently, and they'll talk about kind of the different levels. Let me enlarge this, if any of you. So looking at, and truly, I feel like every hospital is a little bit different, but these are kind of the basics. A level 1, where it's, puree and cohesive foods with smooth texture. So for instance, right now, my older brother, he has significant cerebral palsy. He's had a lot of medical issues. He's been in a long-term skilled nursing facility for the past year and a half. He's finally out, and he's been on a feeding tube. He's been on a feeding tube a couple times, and he's been on one. This is the longest he's been on one, and he's basically getting most of his nutrition via G-tube, but he is able to eat some what we would call level 1 foods. So definitely pureed, smooth texture, something like pudding, that kind of thing. Pureed, mashed potatoes is one of his favorite. I mean, if you're gonna have to be on a puree level, a level 1, mashed potatoes, I think, is the way to go. I'm down with pudding and mashed potatoes. Okay, and then mechanically altered, so things that are easy to chew, not anything too hard. And so it gives you some examples, level 3, and then level 4 is usually regular consistency. I know the rehab hospital I worked at was like level 5. There was 5 levels. So just looking at some of these things, and liquid recommendations, you'll see this a lot too. So let's say you are doing cognitive rehab in a short-term rehab hospital or inpatient rehab. You'll see a lot, they're on thin liquids or nectar thick, honey thick, or spoon. So that's basically pudding level. So a lot of times they're not really what I would call drinking enough. So these are some of our clients who could be dehydrated, especially people who are on more thickened liquids don't necessarily, I say, have enough intake. So just think of that if you had to drink something that's honey consistency safely. So just think about that, various situations you might be in, or let's say you're working with a pediatric client. They have a lot of feeding restrictions, but you're working on language, receptive and expressive, but they're there with you at the clinic and they want to drink. You're like, oh gosh, they're on nectar thick. So these are just little things that occur. And because these things don't happen in a vacuum, a lot of times you might be seeing clients that have all these restrictions, even though you're not treating it. So these are things that you do need to be aware of, or call some attention to your supervisor for. So I don't know how many times this has happened to me as an SLPA. So for those of you who don't know, and I guess I need to add my meet my instructor thing. I thought that was up there, but so I was an SLPA for 9 years before I became an SLP, and some things that happened. I worked with kids who were medically fragile. I worked with kids who we didn't know there was feeding restrictions, and they came to see me, and parents like, oh, they can't have this, they can't have this. Oh, and then they're tube fed. Wait, what? Okay. And then I didn't see that on a report anywhere. So I'm calling my supervisor like, hey, did you know they got a G tube? They're on this? No. Okay. Those are some things that we need to know. So thickeners, there's lots of things with thickeners. You work at any place where we have thickeners, you will learn all the different ways to make something a certain consistency. Because a lot of times too, especially in like a rehab, you're checking on kind of some daily things when you go and you're doing therapy. You're like, okay, do they have the water? Do they need? Do they have do they eat their lunch? A lot of times you're reporting on if they're doing certain things, and you check that out. Hey, they're not really eating, this consistency of food, or they did better with lower consistency. So a lot of times we try to bump people up, but maybe they're just not quite ready, can't handle it, or they'll report to you, hey, I feel like things get stuck, I don't want to eat that. So these are all things that you will take notes of and need to maybe alert somebody about, especially in like a rehab hospital rehab setting, short-term rehab place, long-term rehab, skilled nursing facility, those kinds of things. So, so here's some just examples of compensatory strategies. Chin tuck and head turn are kind of the two main ones we do, especially if they have some, let's say they had a stroke and they've got some weakness on one side. We might just be doing some reminders on their strategies. We're not really treating it, but hey, here's reminders for things to remember when we're going to eat, eat our dinner, eat our lunch. So you can look at all this, and a lot of times there's a swallow guide, especially in those rehab places, or we send something home. And then there are some things we do to help strengthen or kind of get some movement in those weaker structural things. Not, so when I say oromotor, so let me just clarify. We might do oromotor exercises to help strengthen, move. A lot of times it's just stiff. It's not like we're trying to work, get those parts moving again. We are not doing oral motor to improve speech. We're doing oral motor to improve oral motor skills. We are working on that actual skill. And that's really to help, keep them safe to eat. So someone's like, oh, we don't do oral motor exercises. We don't really do oral motor exercises to improve speech. We might do oral motor exercises to actually improve eating. So just kind of know that difference. So there's that, because sometimes you as an SLPA, you'll get a report to do, you'll see an oral motor goal on there and you're going, oh, and then you realize, oh, that's made because they struggle with eating, swallowing, whatever it is, lip closure, get their mouth around a cup, something like that. Well, that might have, you need to have a discussion with your supervisor because you shouldn't be doing that. And a lot of times it's you inherited somebody with these goals and, hey, speech, good, you're open, great. You can hit my 11:30 time slot at the clinic, great, come on in. And then you see these goals, you're like, wait, I'm not treating feeding. So those are just some things to be aware of that occur. Here's some specific, the Masako, Mendelssohn maneuver that we do to help support some of the swallowing. And a lot of what we do too is really work with the caregivers to help the client follow through with what they need to do. So here's the most important slide of this. I think maybe I should put it first, not last. But really, an SLPA should not engage in the following. So performing standardized or non-standardized diagnostic tests. So any of the swallowing things you aren't performing. Perform procedures that require a high level of clinical and technical skills. So obviously you're not doing a fees where you're sticking something off someone's nose. You're not in the radiology suite doing the swallow study. Interpreting results of information and develop or determine swallow strategies or treat medically fragile students, patients, clients independently. So when we say that, typically speaking, medically fragile, again, that's more of a blanket term, and I think that's open to interpretation. Usually your supervisors kind of, especially somebody with more involved needs, they're going to assess whether or not do you have the skill set to work with this client, or how much supervising does your supervisor need to be in because of all the other things you're not allowed to treat. So those are some things to just be aware of, get to know, be familiar with. You will see it on reports. And that's why you're learning about it. Because a lot of people are like, why do we have to learn about it if I'm not licensed to treat it? Because you need to know what it is so you know if you're in a situation that you shouldn't be.
I did need to ask a question about that.
Mm-hmm.
Or you were talking about the oral motor therapy. So we're not allowed to do that, or we are?
Okay. Just hold that thought 1 second.
Okay.
So let me pull up this presentation. Let me make sure this is recording. Okay, yes, sorry. Sometimes I get alerts. I want to make sure it's still recording. Oh, that's the alert I'm getting. My battery is running low. Okay, so a couple different things. Oral motor. So you will see oral motor goals. We don't endorse oral motor for speech to improve speech. But what I want to say about that is you will see that on a goal sheet. And you might see that that's a goal, but it's to address feeding. So if you see that, no, what's the purpose of the oral motor goal? As much as we talk about oral motor is not appropriate for speech production, the challenge is some of these, depending on the client and what the issues, you might see it, but that's probably not a goal you're going to be working on because if there is a oral motor goal on there, it's likely for feeding. Now, if you have an oral motor goal for speech, we don't recommend that either because that's not really, there's no evidence base to show that oral motor exercises improve speech production. But again, I don't want to say never ever. And there might be particular things, like for instance, here's just a perfect example of something I occurred when I was in SLPA. We had a kid, we inherited goals, and it talked about practicing lip closure. So basically what it did, it had this goal with just activities to do. And he did struggle with lip closure on a cup to drink. That was a goal. His outside speech therapist, not a school-based therapist, but it was a problem. And so myself as an SLPA, we just supported him trying to work on cup drinking. But he didn't, how do I put this? So this is where it gets weird, is that he didn't have a swallowing issue. He just really didn't, he could, if he closed his lips and drank from the cup, he could. He had a lot of issues with just getting his mouth on the cup, closing the cup. And once the liquid was in, he could manage it okay. So he didn't have a swallowing disorder. But it's like this SLP, we got, wouldn't be anything that myself or my supervisor would have done on an IEP, but